This podcast is brought to you in association with ANZ Hernia Society, the International Hernia Collaboration, the Abdominal Wall Reconstruction Surgeons Community, Melbourne University, and is now endorsed by General Surgeons Australia. Good morning. This is Hernia Hub. My name is Roshan and I am the host and producer. Happy Diwali to all of our Indian friends. Through our podcast, we're hoping to promote, to inspire, to educate and to inform all who are watching, whilst we continue to learn ourselves and from each of our guests who have joined us to date. The growth is vital and I would encourage you to like and subscribe to our channel. And please continue to share with all surgical enthusiasts. Good morning, Ramana.
Morning.
We've reached episode 7. What are your reflections so far, technical issues aside?
I think things are going pretty well in terms of having quality faculty as guests and then having a free-ranging discussion on all things hernia and beyond. I think we should go a little more on the rough side sometimes, but it's hard. Surgeons generally don't want to be in public talking about things which are not, mainstream. So that's me. I mean, I would always be happy to talk about the controversial things and having heated controversies, discussions, debate. But maybe over a period of time that can come. But so far, so good.
Before we introduce our guest, I have one question for you. Recently, you described yourself as a keen student, and I've observed that it's certainly not limited to surgery. Are all surgeons by nature keen students, or are you just unique?
No, I think pretty much all surgeons tend to be students. At a point of time when they lose interest in their practice and start looking at other things in life, maybe their grandchildren or something, they might stop being students. But I think pretty much all practicing surgeons, especially in the current age, are forced to be students, whether they like it or not. Otherwise, you become irrelevant pretty fast.
Our very special guest today joins us from Cleveland, Ohio. She's a program director of general surgery residency at Cleveland Clinic and an all-round superstar in AWR surgery. Ajita Prabhu, welcome to the Hernia Hub. Thank you for making the time to join us. I know it's late in the afternoon, Cleveland time. Can you tell us a little bit about yourself and what you think specifically makes you who you are?
Thanks so much for having me on. How would I describe myself? I would say I wear many hats, like the President of the United States. So one of them is surgeon, one of them is mom, one of them is program director, so mom to a lot of residents. Outside of that, I enjoy running and exercising a lot. So lots of stuff going on here. In my surgical life, there are several things that drive me and motivate me. Of course, the number one thing is the clinical care of patients. I'm deeply invested in surgical education and surgical education concepts. Clinical outcomes research and the care of hernia patients, mesh and biomaterials are my main interests academic.
So Ajita, you've been in the Cleveland Clinic for a number of years and you were, when I visited, I think in 2015-16, you were in University Hospitals, Case Western University, literally next door. How is life in Cleveland Clinic overall? As a surgeon, how would your typical week be? Do you operate every day? Do you do a lot of research-related meetings? Do you work 16-hour days?
So life here is very busy. It's wonderful and it's full. I would say before I became the program director, I routinely had one full day of clinic, which was Monday, which would start with a 2-hour research meeting and then would have a packed clinic for a full day. And then I had 3 operative days a week that we would fill for about 10 hours.
How many patients would you see on a full day?
Maybe around 30 patients in a full day of clinic.
And these patients would be vetted, seen by your residents or fellows before, or you would see them from start?
So when we are in clinic, we usually have several partners in clinic, and we usually also have several residents and fellows in clinic with us. So the residents and fellow trainees will see the patients and present them to us. Sometimes when the clinic is very busy because we're all there, of course, we'll just jump in and continue to see patients to keep it moving. And then clinic prep is done ahead of time. So most of the patients will come with operative reports. Most of them have imaging studies that we've had ordered before they get to us. In some cases, as with, I'm sure, every clinic, we have to work them up from the beginning. But some of them are multiply reoperative, and so it's helpful to have all of their old operative reports if we can get them ahead of time.
What percentage percentage of your patients in the clinic would be outside the United States, Middle East, and other parts? I know people who have gone there from different parts of the world, but is that common?
I would say not as much. We certainly see international patients, but I would say less than 5% of our patient population is international. I would say probably 20% or so of our patients travel within the United States for their care. So we commonly see out-of-state patients. International patients occasionally, not quite as much. We will have clinic, and then I would have 3 days of OR a week and 1 administrative day. Since I've taken on the program director role, I've cut back to about 50% clinically. So now it's between 1 and 3 days of operating every week, depending on what the week looks like. So I have 2 dedicated administrative days. However, as with every surgeon, probably, I tend to fill some of those with combo cases or with cases that just need to get in and get done. The program certainly takes a lot of time, and there are many trainees in our program. It's a large program. So this takes a fair amount of time. And then we still have full Monday of clinic, although I've scaled back the number of patients since I'm operating a little bit less, and then 2 hours of research Monday morning.
So when you operate, do you operate in one room, or you have 2 rooms or 3 rooms with different people doing different parts of the procedure, and you just, the cardiac surgeons in India, they go through various patients in the same session, just doing the final grafting, anastomosis for the coronaries, etc. So do you do that kind of thing?
That's not my speed. We run one operating room at a time, and largely since taking over the residency program, I'm operating with surgical residents and not with fellows as much, although I do operate with the fellows still some. It's substantially less than it used to be. And so I'm in the OR with the residents the entire time. And although there can be, we never do concurrent surgery here, but there can be staggered starts such that, once the key portion of a case is complete and we're closing, it may be that another room might open up. There's never 2 cases going at the same time. For me, frankly, I like to avoid that circumstance. I think it's too stressful for me. I think it's too stressful for the trainees, and I don't feel that it puts my attention in the right place. So this is a one OR at a time kind of deal for me.
So do you ever get to do the Mickey Mouse hernias, as they call it here in Australia? The simple, straightforward cases, the bread and butter cases for most young surgeons?
For sure. And I will tell you, I still enjoy them as much as I always did. And those are often the most delightful cases to do, particularly with the junior residents, because we can help them learn basic surgical technique. And they also are a good mental break for us. So I would say, yeah, certainly we're doing straightforward umbilical hernia repair, straightforward inguinal hernia repair, straightforward easy cases, lipomas even sometimes, gallbladders, still get to do those. And then most of us here take 1 week at a time of acute care surgery call or emergency general surgery call. So that is for a full week at a time, 7 a.m. to 7 p.m. At night, we all rotate through individually and take individual nights. So the day surgeon is on for a week at a time. Then all of us take the nights 1 night at a time. That is an extremely busy service, and that has everything from small bowel obstruction to paraesophageal hernia to whatever full range of general surgery emergencies, free air, etc., appendicitis. And so that keeps us sharp, and that's always an enjoyable but intense week.
So it sounds like a 60-hour a week.
Maybe. It certainly doesn't feel like that to me. I think the weeks that I operate more, I'm definitely at work for longer. I wouldn't say that it's insurmountable by any stretch of the imagination.
You are very well known across the world for being part of various academic publications and being lead author in many and senior author in several others. How many papers have you actually published, and what would be the most memorable or most painful ones that you've been involved in?
So there are about 150, 160 publications that have my name on them. And I'm fortunate to be part of a big group of surgeons that is academically inclined, and we have plenty of trainees in our lab. So we're able to be productive in ways due to sort of the synergy of the group, I would say. And that for me has been a really productive and supportive environment to grow my research. So that's been wonderful. As far as memorable publications and painful publications, I will tell you that we do some work around prospective clinical trials, as you probably know. And the joke in our group is nothing matters. All of our interventions end up without a significant outcome, which is sort of our day-to-day clinical joke about, what is it that we're doing here? And I say that a little bit tongue in cheek. We look at the technical aspect largely of ventral hernia repair, although we have done some work around foregut surgery and paraesophageal hernia repair that is emerging currently. But, I jokingly say this. I say that not to dismiss the work and not to minimize its importance, but when we drill down to look at things, for instance, like heavyweight versus medium weight polypropylene, does the weight of the material matter? When we find that our clinical outcomes are roughly similar, then you go back and you think about how much effort it takes to enroll patients in a randomized control trial after you design the trial, after you've gotten it through your local IRB, after you've potentially gotten other centers involved and gotten through their data use agreements, and then you're consenting the patients in clinic, then you're following them, you're getting their clinical outcomes, and then to have, similar clinical outcomes in both groups can be a real disappointment, shall we say, when we're designing these. We've certainly had our experience, I would say, with some painful outcomes in that regard, just in terms of sometimes wondering, do our interventions matter? Do our debates about the technical aspects of hernia surgery matter when it comes to clinical outcomes? I think that part can be extremely challenging. I don't think that in any way it dampens my enthusiasm around the work. And I think that it's important to have academic inquiry around some of these concepts and to chase them down and get an answer. And then if we find that there's not a difference in clinical outcomes, then we have options on how to interpret that data and how to employ it in practice. I don't think it loses its meaningfulness necessarily. I think it matters how you interpret it for sure. We find sometimes our interventions don't have a gigantic clinical effect and may not be practice changing, and that can be a real disconnect.
Give us a couple of examples.
A heavyweight versus medium weight mesh, in which I can't remember the full number of patients that we enrolled in each arm, but ultimately determined in terms of wound morbidity, hernia recurrence, et cetera. There is no essential clinical outcome difference in the weight of polypropylene mesh select.
A couple of years back, I was on a conversation with Rosen, and he said as much that he stopped using anything other than heavyweight polypropylene meshes for the most part. Did I get that right?
Yeah, that's actually what he's done in his practice. I think largely related to, as you probably know, some patients may experience central mesh fracture for unclear reasons, and we haven't experienced that truthfully in heavyweight polypropylene mesh to any describable frequency. And so I think he's leaning more towards avoidance of central mesh fracture in knowing that there's likely not a difference in terms of wound morbidity or hernia recurrence or pain.
But did you ever see mesh fractures, CMFs, in anything other than Versatex or ultra light polypropylene meshes, like in regular Prolene soft mesh, etc.?
Yes. In medium weight polypropylene monofilament meshes, we've certainly seen central mesh fractures. Obviously, they're more common when the midline fascia is not approximated. So in a bridged scenario, which I think is a little bit different, when the midline fascia is approximated, I have seen a central mesh fracture when there was a separation of the muscle after surgery. For instance, I've had a patient that gained a lot of weight after surgery and managed to not only have a small separation of the muscle, but also a central mesh fracture. And that was with medium weight polypropylene mesh, not ultralight weight polypropylene mesh. So we've certainly seen it a handful of times. Does that raise a gigantic signal in terms of an FDA kind of conversation? I don't think so. I think, however, when you take those patients back, the morbidity associated with a recurrent hernia operation or even just the recovery period for the patient, as we all know, is undesirable. So I think in that regard, Rosen is probably erring on the side of avoiding that potential reoperation, even if the risk is low.
So a couple of questions come to mind with regard to this. One is it fair to say that a central mesh fracture does not occur without a facial dehiscence, number one? And number two, biomechanically, a mesh is designed to withstand the maximal stresses on the abdominal wall physiologically. It exceeds, in terms of the newtons, the amount of force that an abdominal wall or a repair normally would be subjected to. Why do you think a medium weight polypropylene mesh would fracture in certain situations?
That's a good question that I'm not sure we know the answer to. I think that is the $1 million question probably in hernia repair, which is what is the perfect material and what are its characteristics, which I think we still have not answered. As far as the fascial dehiscence question goes, I would hesitate to say always or never in any regard with anything for hernia repair. I think you'd probably agree with me on that. I think it's highly more likely for a central mesh fracture to occur when the midline fascia was never reapproximated or has separated, or if there's wound morbidity leading to an anterior fascial closure breakdown, for instance. I do think that there's a higher risk of a central mesh fracture, and likely that risk is higher in a midweight polypropylene mesh than it would be in a heavyweight. Why is it that a midweight polypropylene mesh, which is designed to have stronger force tolerance than the physiologic abdominal wall force, and yet it can still break? I don't know the answer to that. And I don't know if that relates to, although these meshes are ideally inert in the in situ position, is there some breakdown of the mesh? Is it that its composition changes over time and becomes more brittle? I don't know the answer to that.
There are any new developments in the polypropylene mesh products available to you, in the sense that the heavyweight mesh, would you say that you have any macroporous meshes which are of that weight, 90 grams? We are talking of 90 grams and beyond.
Right. Or 75 grams probably and beyond. But no, I think there is one new device that we have been using, we have an experience with that's been positive, which is SurgiMesh, which is a multifilament or polyfilament heavyweight polypropylene mesh, it comes in large sizes. So 50 by 50, I think there's a 40 by 40 size centimeters in that device. And we've put a few hundred of them in and are currently going back to look at our outcomes to see how we've done with them. So far, they seem to be performing well.
Which company is that?
So BG Medical, which their address on their website is in Illinois.
Incidentally, I'm pretty sure you still don't have it. There is a PVDF mesh known as Dynamesh, which is basically a German product sold by a company called Dahlhausen and marketed widely in Europe and in some Asian countries, including India. That is a fantastic mesh. It's 140 grams. And it's macroporous, more than 1 millimeter pore size. And it's a great product to have. Of course, no conflict of interest, no disclosures. It's just a matter of fact that a heavyweight mesh, which is macroporous, is pretty much what all of us would look for. Talking about meshes, I believe the titanized meshes, polypropylene meshes, are now available in the US. Yuri Nowitzki has started using them. I don't know since how long and how many he's put in, but do you have any experience using these meshes?
I don't, but I always have curiosity. Anytime there's a new device there, I think it's always worth figuring out how it performs. And I don't actually have any issue with trying new devices. I don't have particular experience with that device, but would be curious to hear how it's performing over time.
Just, because some of our audience may be curious about this, let me just say that the Dynamesh or titanized mesh is polypropylene, which is nano-coated with titanium. So it tends to be anti-adhesive. So you could use it as an IPOM mesh, and you can also use it in the extraperitoneal or retromuscular space. Now, this sounds suspiciously like how a physio mesh was marketed as, you can pretty much put it on your window and it'll do a miracle job of preventing the storm from coming in. So I have used titanized meshes while I was in India, and I don't think it does very well in the retromuscular plane. After TARS, I have explanted very few meshes, but I can definitely remember them being titanized meshes. The same reason, because if it's anti-adhesive, the integration to that space, to the tissues in that space, isn't going to happen very quickly. And you're going to pretty much have a lot of fluid and the mesh swimming around or floating around in that, and tends to get infected. Anyhow, so that's a different conversation. Interesting to talk about mesh products that we might have used.
what's been happening with respect to TAR recurrence data? And what do you think of papers that show a less than 5% recurrence rate?
As far as TAR recurrence data goes, when you say what's been happening to it, what do you mean specifically?
The composite recurrence reported in your center shows that 1 in 3 of these cases will return with a recurrence. Now, if you compare that with studies from around the globe from different centers, which report retrospective studies for the most part, in general, they report recurrence rate of 5% or less, and generally in single digits. When a center like yours, which does such high volumes, reports recurrence rates that are that high, it does force one to pause and reflect and re-examine one's presumptions that the TAR was a silver bullet and the ultimate AWR solution. There was some comment, and indeed this is controversial, that with such high recurrence rates, perhaps this center should stop doing TARs. Of course, that's an outrageous comment, and you had a significant part to play in the publication that triggered all of the controversy around this. I'm just interested into what your opinion is. What's your take on all of this?
Sure, I'm happy to talk about that. I love that conversation. And I think probably it bears some contextualization of what is being reported. It doesn't surprise me whatsoever that some centers are reporting lower rates of recurrences. And actually, if you look at our retrospective paper, I think we reported on around 1,200 patients with long-term follow-up. And a couple of things are notable about that, one of which you touched on. So one of which is, how do you define recurrence and what are you calling a recurrence? So when we refer to composite recurrence, that also may include an arm of patients that have described a subjective bulge. Many of those patients may not have returned for a CT follow-up or a physical exam, and that may leave us in the situation of saying, okay, the patient is reporting a bulge. Perhaps we would consider that. So out of the utmost sensitivity toward considering every finding as a recurrent, that patient that has a reported bulge that does not have follow-up CT imaging or a surgeon exam still is counted as a recurrence in the way that we consider a composite recurrence. Why? Because if we don't see them and if we don't have a CT to prove they don't have it, our assumption is to err on the side of a clinical recurrence so that we don't underestimate the incidence of our recurrence.
Aren't you overestimating it?
So for a couple of things. So you may be overestimating it, but I think also otherwise that patient is completely lost to follow-up. If there's no CT or no surgeon exam, there's no way to describe what their outcome is, right?
Don't you have a regulated, mandated follow-up, and don't you take a commitment from these patients?
I mean, it's, essentially we encourage them to come once a year. Our standard of care in our group is once a year follow-up with CT scan. But as we all know, many of these patients float away, and if they're feeling good, they may not come back. Some of them are traveling for their care, and that may relate to why they're not willing to come, but that fully doesn't explain the loss to follow-up that is pervasive throughout all of hernia repair. I think we all see that in our practices. So it is true that we strongly encourage them to follow up. For our standard of care, it's once a year with a CT scan, but they don't necessarily comply with that. The other thing is that if you look at that paper, we did a sensitivity analysis for all the patients that were lost to follow-up. So in a sensitivity analysis, when we have a retrospective set of patients and we are missing data, we make the statistically worst assumption of what the outcome could have been, and then the statistically best assumption. So if all of those patients were lost to follow-up had a recurrent, then what's our recurrence rate? If all of the patients that were lost to follow-up did not have a recurrence, then what's our recurrence rate? And within that, we found that best case scenario was a 5% recurrence rate. And I think worst case scenario was maybe a 25 or 26% recurrence rate. That range is absolutely there and reasonable. And then the other thing I want to point out is that our TAR population that we reported for that paper, I think it was almost 60% recurrent hernias that were being operated. It may also have to do with the phenotype of the hernia in terms of its size, in terms of the technical aspects of the repair. So we really don't know. And what I would say is it doesn't worry me whatsoever that some centers are reporting low rates of recurrence. It may well be that in their patient population with tight follow-up, they have low rates of recurrence. And it may be that those hernias were not reoperative. It may be that they weren't that complex. And maybe if we get rid of the recurrent hernias from our group, if we were to take the first time TAR repairs, could we get close to 5%? That wouldn't surprise me at all.
So you published on redo TARs and another one on bridged TARs with a 50% recurrence rate, right? And was that Zolin, first author?
The bridge TARs was Al-Khatib,
Al-Khatib.
first author, and I was senior author on that paper. That is correct. And then the recurrent ones, I think, was Zolin.
Now let's move on to your other publications. The Cleveland Clinic seems to have a kind of penchant for publishing things which disprove what the rest of the world seems to believe in. And you are there's a perception amongst the hernia community that Cleveland Clinic is contrarian to mainstream thinking. For example, everybody says smoking is no-go when it comes to major AWR, but you people don't stop your patients from getting under the knife. And
we encourage them to smoke. I'm teasing. That's a joke.
I know that. But why do you think this is happening? That your data seems to be different from what everybody else is saying.
So I think that's always a funny perception. I don't think that there's any particular intent to be contrarian or not contrarian either way. Our work is largely based around shaping a question and then going and answering it based on our experience, right? So when we look at smoking, if we look at what we reported, we compared, I think it was 300 or so never smokers to 100 active smokers undergoing AWR. And we reported...
Wasn't it 432 each? That was 432 each.
No.
That's a Petro paper, right?
I'm just looking to see. I have it open next to me here, PubMed. I just want to make sure I'm talking about the one that you mean. So
the original one that I'm talking about is probably Clayton's paper with 432 patients, which were propensity matched in terms of BMI and
that one was 100 to 300, if I remember correctly. Let me just see if I can pull it up real quick. I keep getting the follow-up one. Yeah, 418 to 418. I'm going to just start the answer to the question again. Okay, so when it comes to smoking, first of all, when we talk about our papers and the way that they may be viewed in the hernia community, I just want to say that we as a group don't particularly consider our work contrarian or not contrarian either way. I think we formulate questions that are of academic interest to us, and then we report on our experiences as we experience and as we interpret them. With regard to the active smoking paper, we matched 418 current smokers to 418 patients who had never smoked. And they were undergoing elective open ventral hernia repair, all clean wounds, and we looked at their 30-day outcome in terms of wound morbidity, and then we also looked at 30-day all classes of morbidity as a composite outcome as well. And what we found was that although there was an increase in the rate of wound morbidities postoperatively in the active smokers, this was driven largely by cellulitis and seroma, largely did not require any type of procedural intervention, did not result in mesh explantation. And then we subsequently published just recently here, follow-up to that paper, propensity matched 100 active smokers to 300 non-smokers, and found that there was a slight increase in wound morbidity in the active smoker group that in that case did not reach statistical significance and did not result in any longer-term mesh explantation or further process. So how do we interpret that? I think that it's not uncommon for that to be received as advocating for patients to smoke and for us to take them to the operating room. And I would say that perhaps the discussion should be framed a little bit differently. When we interpret that data, I think as physicians and people who care for patients and know that there are lots of negative effects of smoking, we have a visceral response, which is to say, you should stop smoking. It's not good for you. And our data can be interpreted as saying, go ahead and smoke. It's okay. We'll still repair your hernia. The truth is probably somewhere in the middle. We continue to counsel our patients strongly to stop smoking before we take them to the operating room. But we no longer use that as a reason to avoid surgery in symptomatic patients. Now, for patients who are higher risk, who have had multiple repairs, who have had severe wound morbidity and deep or organ space infections, that kind of thing, of course, we're a little bit more aggressive in getting them to stop. Should this be interpreted as, hey, the hernia group from Cleveland Clinic is running around telling everyone to smoke? I think that might be a little bit overly interpreted for what the intent is.
What about marijuana?
In terms of marijuana, I think it's the same thing, right? Like, I don't think that we would actively encourage our patients to smoke marijuana, but I think that the complication rate that we experience is similar. We don't see a technical difference in their outcomes. And so for us, I think that one might be a more ideological discussion or more philosophical discussion, but where the rubber meets the road for hernia.
With marijuana, one can afford to be philosophical.
Exactly.
This was, again, a publication of this year or last year. Nir Messer was the first author, am I right?
Sarah Maskell was the first author, and that
Sarah
was
Maskell.
in the past year.
Correct. Now, talking about these publications, even though we never really got round to hearing you, thanks to me interrupting you, what were your most notable publications that you would like to talk about? At some point of time, we'll have to come back to that question, but we might actually be discussing some of them in the course of this conversation. What is your general feeling now, after probably the few years that have gone past since you published, on the role of robotics in ventral hernias as well as inguinal hernias? The PROVIT and the rival trials created a tremendous amount of backlash from the robotic surgical community, and pretty much a strong opinion has been that you're killing the insurance deal for robotic surgeons in the United States. And obviously what happens in the United States has a ripple effect on the rest of the world. And so I'm sure everybody tends to get worried that what is intuitively a great platform to do minimally invasive surgery is now, thanks to your publications, which also has been kind of painted as the results being due to the surgeons not being as experienced or expert as the well-known advocates of robotic hernia surgery are. This entire thing seems to be a very hot and passionate issue. Now that it's been 3-4 years since these publications came through, where do you stand? What is your overall perspective on this? Now that you've published, you've got it all on JAMA and Annals, and you've ticked all the big boxes. Now, where do you stand on the role of robotics in inguinals and in the ventral space?
First, let me just say, I think largely philosophically, I stand in the same position that I did at the beginning of the conversation a few years back, which is that I think it's interesting technology that should be explored for applications in hernia surgery. And I think I've said that fairly consistently since the beginning, and nothing has changed in that regard. I don't have a bias against robotic surgery. It doesn't have a clear routine application in my practice from day to day. We discovered what we discovered for the rival trial, and I know there was a lot of controversy around inguinal hernia. And I think that there is certainly philosophically, for surgeons who did not find laparoscopic inguinal hernia repair an approachable technique due to learning curve, due to technical difficulty, there are certainly surgeons who feel that the robot has enabled them to provide minimally invasive hernia repair for inguinal hernias. And I think that's an okay thing. I think that's always been an okay. I think for surgeons who have learned it laparoscopically, for me, I just simply haven't found a benefit to performing that operation robotic. I do know that it obviously costs more. And I think in many cases that operation takes longer, although I would say a surgeon that's facile on the robot is probably pretty quick at an inguinal hernia repair. And if they have a good team working with them and they can dock quickly and undock and get the room turned over, they can probably do several cases in a day. So there are absolutely teams that have that down. I certainly don't begrudge them any of that. I think if that works for you, that's wonderful. I'm facile at doing these laparoscopically. It costs less. It's quicker for me. And I get it done and I get on with my life. So I think the clinical outcomes part of it is what you would expect it to be, which is similar across the board for robotics and laparoscopic inguinal hernia repair with mesh. As far as ventral hernia repair goes, we are exploring the robotic platform right now for open ventral hernia repair versus robotic ventral hernia repair in patients undergoing retromuscular ventral hernia repair. So that trial is ongoing at our place, and our surgeons are enrolling in that. And so we'll see. For IPOM, I'll be honest in saying, my recurrence rates were certainly higher in my pilot study for the IPOM robot group versus the lap group. Although it was a small group of patients, I would consider that to be a pilot study. And honestly, if you interpret that data very literally, it could have been statistical variation one way or another. So is that enough to damn the robot? I don't think so. What I would say overall, though, is as robotic technology continues to emerge, there are different platforms coming out on the market. We certainly will plan to continue to engage with them and explore their applications in hernia surgery. Truth be told, it would not surprise me if in the next 10 to 15 years, laparoscopic platforms are dead and robotics is laparoscopy, and that's the way that we are going.
Absolutely.
And I don't think that there's anything wrong with that. I think that that is totally fine. I also think that as new technologies emerge, we should continue to explore them. And I think someone has to describe their outcomes when it comes to that. I think it's not more than that. I feel dispassionate about it. We are participating. We are one of the enrolling sites for the Hugo FDA trial to establish safety for ventral hernia repair applications here at my place. And so we continue to engage with these platforms. A lot of our publications and a lot of our commentary has been interpreted as, these people hate the robot. I would simply say I don't draw that conclusion from the publications. Also don't think, I think that there are plenty of surgeons who are prolific on the robotic platform. And I think that where possible, it's helpful to publish those outcomes so that there's a counter. And I think when there's no counterpoint, then it's difficult to have a comparative conversation. So I would say we just don't have.
You have an 8 to 10 centimeter M3 hernia, incisional, and you have a similar size subcostal hernia. Would you approach any of these robotically in an average patient? Will it give or take whatever BMI you want, whatever gender you like?
I'll be fully transparent in saying, it's pretty quick for me to do an open retromuscular repair.
Is that the only criteria?
What?
Because it's quick?
Not necessarily. So the other criteria, though, I'm waiting for that to be established. I want to see what we find in our trial. To answer that question, I would just say, for 7 to 15 centimeters, that's what we're looking at for the population for study in our randomized trial. And I would say for the robotic TARs that I have done in the past, I think that they've gone well. I've been satisfied with them. Largely, our patient population requires soft tissue resection because they may have soft tissue issues or scars or things that need to come off. Understandable. So that's a little bit of a different category of patient. For a patient that, for all intents and purposes, could undergo either operation for an 8 to 10 centimeter hernia, I think I just don't know the answer yet. I don't know yet if there's a clinical outcome advantage for a patient to undergo a minimally invasive procedure over an open one. So I have curiosity about where our data will go with that. But I will say, if there is an application for robotic surgery in ventral hernia repair, that to me would be potentially the most compelling one. So that's the one I'm most interested in.
Are you in that stage of the Dunning-Kruger effect, or whatever one chooses to label it, where you would say that you speak only for yourself when you talk about things like robotic is not any better than laparoscopy or one versus the other, whatever one is analyzing in one study? So would you say that I speak only for myself, or my center speaks only for itself? We don't want you to change your life or your practice. I leave it to you. Are you being a relativist? Or would you say that, listen, we know what we are talking about and we have a much higher level of experience. We have done in-depth analysis, and you better listen to what we are saying, honestly.
I think to be dogmatic in anything in surgery in general.
This is not dogma. This is not dogma.
To ask for heartache.
This is being assertive about one's own research and one's own academic integrity. And when I'm saying academic integrity, I mean the veracity of one's data.
So I would say my interpretation of our data is, in our group's experience, this is our findings. This is what we find. We report them honestly. We will share that experience with whomever is interested to hear it. Do I speak for the whole world? Absolutely not. I would say that we can't speak for a large volume of surgeons that are prolific on other platforms and in other approaches, and they have the capacity to speak for themselves, and they should. To assume that one's findings can be the only answer is probably short-sighted in all regards for anything surgical, whether it's
Then why bother
anything else.
doing expensive randomized controlled trials?
Because we love it.
If your
Right.
publication is not going to be applicable to my practice, why should I bother reading your data?
I mean, I don't think that anybody would force any other surgeon to read anyone's data. To me, I
It's
think
not
that
forcing. That's not
no,
the.
certainly, but I certainly wouldn't insist that everyone should read my papers or anything of that regard. I think to me, I'll just say this frankly, I'm not writing it for the readership. I'm writing it for myself. I'm going and doing the research because it's interesting to me. I'm looking to answer a question. I'm reporting on the experience that me and my group have had when I'm writing, and I think my partners would feel largely the same. How others interpret that is entirely up to them. That said, I will always stand by my findings. I write with integrity and I write what my findings are in an honest way. I think it would be misguided to have an impassioned response to how other people react to my research.
Okay, that's an exceptional attempt to try to get you to be controversial.
Bring it! I love it so much. It's so fun. Wait, did it work?
I think so. So, slightly easier question to follow that up. Obviously, you have many projects on the go and you're constantly studying various things. What's upcoming that you're very excited about?
So I mentioned a little bit about randomized control trial we are doing looking at open versus robotic retromuscular ventral hernia repair. It's one of them. We have one project going on where we're looking at mesh versus pledgets at the hiatus in terms of crural closure for hiatal hernia repair. We have a publication that'll be coming out soon on anterior gastropexy versus no anterior gastropexy at the time of paraesophageal hernia repair. And then we're doing some interesting work around narcotic.
When you're saying anterior gastropexy, are you talking about DOR or are you talking
No,
about
we're talking about
exciting to the, all right.
paraesophageal hernia repair. And we're doing some work around opioid use after inguinal hernia repair. And then the other one I wanted to mention was suture versus open retromuscular repair. So 4-to-1 small bite closure versus open retromuscular repair for small incisional hernias up to 6 centimeters in greatest width. So we have some exciting work coming down the pike for all of those areas.
Which reminds me, a few years back, there was a talk of Ponsky and Rosen working on a randomized controlled trial of inguinal suture repairs for the young pediatric hernias versus a mesh. I think for the 16 to 18-year-old age group where you're always debating whether you should put in a mesh or you should just put in a suture and close the sac off. I never really read that paper if it came through.
They did a few up front and the recurrence rate was not tenable. If I remember correctly, I don't know the details of it because I wasn't specifically involved in it, but I think it became not a reasonable clinical question to ask. So they did not do it, to my understanding. They were talking about it.
Now, in terms of your upcoming research and your upcoming projects, the grapevine has it that the clinic has been working on a tension measuring device and whether it takes it to the next level of offsetting the tension with some kind of device to bring the facial edges together. Are these projects that you could talk about?
So this is some of the work by my partner, Ben Miller, who has essentially retrofitted a tension measuring device so that it can be used operative. That device, though, is not available for commercial usage and is just something that has been, it's been for proprietary use, I would say, to date. That device, though, hasn't been used for a clinical outcome as such. We have utilized it more to describe tension changes for the anterior fascia that might be associated with incision of the posterior rectus sheath, takedown of the posterior rectus sheath, transversus abdominis release sequentially. And then, I think currently he's looking at the tension on the fascial edges for open abdomen, et cetera. So I think he's using it more in the iteration of trying to describe what are the baseline physiologic findings or average types of physiologic findings you might have when you're performing certain procedures, such as component separation, or just describing the physiologic tension on an open abdomen, say, for somebody who's undergone catastrophic surgical event of some sort.
Tell us a little about what your center's current position is vis-a-vis closing the midline fascia at all costs at high tension. And your recent publication was that it doesn't affect the outcomes for the most part. And this was again earlier this year, closure under tension.
Are you talking about abdominal wall tension and early outcomes after posterior component separation? Does a tension-free closure really matter?
DLDR was it really doesn't.
So here was the situation with this one. Without looking quickly at with the defects, the concept behind this paper was really looking at when we do component separation, do we truly take the tension off the midline closure? And I think in hernia, for many years, we have been chasing after what we have considered to be a tension-free repair. Oh, I took down the posterior rectus sheath, I did a transversus abdominis release, and now I can close the midline fascia together. There's no tension on that closure, and I'm happy with it, and I can go home. Dr. Miller was trying to describe whether there's some residual fascial tension on the midline when we do these big TARs. And the short answer was yes, it seems that there continues to be some tension on the midline. However, the fascial reapproximation is something that we can achieve safely in most cases. For this paper, I don't think he looked at patients with gigantic hernia defects. There were like 30 centimeter hernia defects in patients that were morbidly obese that we're looking at, the ones that might be at risk for abdominal compartment syndrome. I think what he was looking at is the more garden variety abdominal wall reconstruction patient where we know that there's a high chance we're going to get the fascia closed, and just looking to see is there any residual tension there. And he found that there is some residual tension there. So maybe we're just describing the physiologic outcome of our repair, that there's always going to be a little bit of tension on that midline closure. And that doesn't necessarily need to change our practice, but it's just something for us to understand. I think it's just that. I don't think it's more than that.
You have also published the TAR doesn't necessarily lead to defect closure. It is the release is because of the posterior sheath release, not additionally from TAR, and yet you continue to do so many TARs. Can you explain how this happened?
Absolutely. Physiologically, can I fully understand why that happens? I think it is because where the posterior and anterior sheath invest, I think the takedown of the posterior sheath releases the tension of the anterior and allows us to bring it together. And that's what we found in our measurement. The physiologic tension on each anterior sheath, as measured individually, decreases with the takedown of the posterior rectus sheath. That incision and then the dissection of the posterior rectus sheath is what gets the most advancement of the anterior sheath. So why do a transversus abdominis release at that point? And the short answer is because it allows the posterior components to medialize and gives us a wide space of overlap for our mesh. The physiologic contribution of the transversus abdominis is not the release of the anterior sheath, but it is more the decrease or minimization of tension on the posterior component. And I will say that having reoperated on several patients who have undergone an eTEP with inadequate posterior components mobilization and therefore had a catastrophic posterior sheath breakdown, I can say that getting the posterior components together without tension is of the utmost importance. That is a technical necessity to the operation. But then the other part of it is if you have a good 10 centimeter defect, for instance, and you want to get wide overlap, the way to get the widest overlap into the retroperitoneal space is via a transversus abdominis release. So we are doing it for the posterior components aspect and not for the anterior components aspect.
Why would you need to do a TAR if that posterior closure is all that you're looking at? I could simply use the hernia sac and just do a reef stopa, and then I should be able to get a 25 centimeter defect together, or a 20 centimeter defect together. Forget about it. Talk even 15 centimeter defect together.
Sure. You might be able to do that. I would say in patients, though, that have a not broad rectus abdominis muscle, which is many of these patients, then your space for placing mesh may be substantially limited.
No, but it doesn't happen in real life. How? Can you close a 15, 20 centimeter defect without a myofascial release? And if TAR doesn't lead to anterior mobilization, then why not do ACST for all these cases?
You probably could. In my experience, I think it's exceedingly difficult to get the posterior components together without it, though. I think there's commonly tension on that, and I think it's...
So what if you use the hernia sac?
That, in my experience, hasn't been something that I've done a lot of, to be honest with you. How are you saying technically you use the hernia sac? Where do you put it?
So you put it on the peritoneum where you've gone in and you've mobilized the adhesions. You simply flip over the hernia sac because it's still connected to the posterior sheath and you close it. That's pretty much what is done in the peritoneal flap closure, the Edinburgh flap closure or Malmo flap closure, whatever you call it.
I've seen that described. That technically hasn't been something I've had a lot of experience with. I was just recently at the American College of Surgeons where we had one of our colleagues from Mexico was describing that repair. Simply put, I just haven't had a lot of experience with that. That's not something I do day to day in my practice.
To my mind, this still remains a little unconvincing. You would do a TAR only for the posterior component and not for the anterior, and yet you manage to close these large defects without doing an anterior component.
But 99% of our patients will have their fascia reapproximated with that. So is it that there's some additional contribution from the transversus abdominis? That's not what has panned out in our literature so far, in our data so far, but we'll continue to explore it and see what we get. What we do know, though, is that we have a strong experience of getting the vast majority of these midline defects closed, regardless of how large they are. It's not, I will tell you, it's not Botox, perioperative pneumoperitoneum. It's not any of those things. Correct. I think that there is some remaining question as to how that happened. The only other thing I will say is that the sequential use of figure of 8 sutures in the anterior sheath can get even some of the largest defects closed. And that is a technical thing that I think many surgeons with a lot of experience with this would agree. The more you place sequential figure of 8 sutures without tying them down, the more that takes the tension off the anterior. So does that contribute?
Absolutely. Do you still not use Botox?
We do not use that routinely in our practice.
And why is it that you have not gone into an RCT on the use of Botox in the management of these large hernias?
That's actually in the works for an FDA trial and has been temporarily put on hold for some FDA reason, so has not gotten off the ground yet, but we're trying to stay tuned for that to happen. That is something we have been discussing.
Are you seeing a lot of these post-eTEP blowouts and linea semilunaris injuries? What is your overall understanding of what is happening in your community of surgeons? Is it pretty much like a Wild West of robotic AWR, which is damaging patients?
I hate to say it's a Wild West of robotic surgery damaging patients. Largely what we're seeing is when there is a misadventure with an eTEP, if we go back and talk to the surgeons that had the trouble, we'll ask, did you have difficulty closing the posterior sheath? And 10 out of 10 times they'll say, yes, it was under tension. And I tried to get a little more lateral. And then for reasons that are probably individualized, I think what ends up happening is the space is insufflated with pneumoperitoneum, the retromuscular plane. Perhaps that puts additional tension on their closure. They're having difficulty technically getting that closed. Maybe they drop the pneumoperitoneum, maybe they don't. Then they get out into the lateral abdominal wall in an effort to try to get those posterior sheaths closed together. And I think that that is when the linea semilunaris injury occurs. So the most common thing we are seeing is a disruption of the posterior sheath with unilateral or bilateral semilunaris injuries. Why that's happening, I suspect what happens is that surgeons may be reticent to change their modality of approach. And I'm not saying robotic versus not robotic. I'm just saying if you're there robotically and doing an eTEP and there's significant tension on the posterior closure, even after you've dropped the pneumoperitoneum and tried all of the tricks, then the options are to bail and do an IPOM, to do transversus abdominis release to get those posterior components together, to convert to an open operation to see if you can in any way alleviate the tension on the posterior sheath. But something has to be done differently at that point. And I suspect that there's a reticence to change whatever the surgeon is doing at that point. Like maybe they're just saying like, okay, one more bite, one more dissection, a little more laterally, and I can get that thing closed. So I think that we can see how that might happen. Honestly, I'll say that I have found the eTEP to be a cumbersome operation. I've done many of them and found them to be fine. I think they're beautiful dissection. I've never enjoyed the crossover aspect of it. I find it to be of relative not great advantage over an IPOM technique.
And you're talking about laparoscopic eTEP.
Laparoscopic eTEP. So usually for mine, I had gotten in laparoscopically and then docked the robot. So even robotically. But I think either way, pick your poison. I think it doesn't matter. But to me, I would take a robotic or laparoscopic IPOM over an eTEP at this point, because I think, frankly, it's a straightforward operation when done robotically or laparoscopically. If it's an IPOM, I think it's quick, I think it's well tolerated. And to me, it keeps you out of making an uncomfortable decision when you can't get the posterior elements together. So I think it may prevent an unnecessary additional movement in the operation.
So wait a second. You guys have pretty much warned the world about the dangers of an IPOM and encouraged them to move out of the peritoneal cavity while placing in a synthetic permanent mesh. And today, over the years, I have interacted with so many experts in different parts of the world, especially Europe and US. I hardly see more than a small handful of surgeons who are true blue hernia surgeons who would be caught putting in an IPOM mesh. Most people would do it when there's no other resort. Everyone is now into extraperitonealizing the mesh and getting into trouble doing so and piling on hours of frustrating work. And now you say that it's faster and easier to do it IPOM. Of course we knew it, but you said not to put in IPOM meshes because bad things can happen over the long term.
I think we have some pretty compelling evidence from Kokotovich to suggest that the long-term rate of mesh-related reoperation associated with IPOM mesh is less than 5%. And so I think medical reversals are not uncommon. We've seen them many a time in surgery, medicine, anything else. So I actually think, to me, I think it's important to be able to shift our position on things as we see literature that supports whatever the right thing is that we might want to do for our patient. And I'll be honest in saying, I also, to be fair, I had a YouTube video from a SAGES debate where my assigned topic was put the mesh retrovascular, so like there are always kind of comments like that you'll see. It is true that my position was previously get the mesh out of the abdomen. Why would you want the mesh in contact with the viscera? And that is absolutely something that in the past, that's something I certainly would have said. Fortunately, we're capable of evolving. We're capable of interpreting literature as it comes along. And I think what we're seeing is in a frenzy to get the mesh out of the abdomen, we're starting to do operations that don't make a ton of sense. Also, you are correct in saying that many of the hernia community would say that an IPOM is not something that's desirable. But I would also say the vast majority of surgeons, probably in the United States, India, and the world around, who are not the ones who are commenting on social media, who are not publishing heavily, but who are doing the vast majority of these operations are probably doing IPOMs. Let's just be honest about it.
Say I come to you, fairly decent shape, with a 6-centimeter primary umbilical hernia. What are you going to offer me?
IPOM, 100%.
And if I had a right inguinal hernia along with...
For that, I would probably do a laparoscopic inguinal hernia repair at the same time, or open, depending on whatever the patient condition is.
Definitely not an eTEP person from what we can now make.
Well, I think, again, I think it's important to try to understand what we're getting out of it. If the main priority is to get the mesh out of the abdomen, then I can understand why a surgeon might want to do an eTEP. But am I fully...
Also about a pain-free recovery.
Yeah, and perhaps that's true, but if you have a pain-free recovery complicated by a posterior sheath breakdown and bilateral hernias semilunaris injuries, what are we winning for you?
What's the incidence of that?
Well, I'll tell you what it's not. It's not zero. And I'll tell you where those patients are coming. I would just say, simply put, I think it's important not to polarize our opinions on all of these things in terms of like, oh, we said one thing, so we can never change that thing. That doesn't make sense because I don't think that that's the pursuit of medicine or surgery at all. So I think sometimes we go down these sort of hotly contested topics and we say like, it's got to be this. It can only be this. That's the answer. And I think time will prove us wrong every time. To me, I think it is important to be able to continue to process literature as it presents itself and our experience, not just my group, but the world of surgeons' experience, and see where we go. And I do think that surgeons in general have the right thing for their patients in mind. The reason to be passionate is not to win an argument with another surgeon. The reason to be passionate is to provide the best care for your patient. And so if we're saying things dogmatically, if we're not willing to change our position, then it's not us that gets hurt, it's the patient. So to me, I think this all has to be processed and taken into context as we go. For me, I think what I have learned as I've evolved is the frenzy to get the mesh out of the abdomen probably isn't a prize worth winning. To me, I think if I can get through with the straightforward IPOM, less than 5% of these patients are going to have a mesh-related complication or need some additional intervention related to that problem. That to me is a win over potentially putting them at risk for other complications for an operation that is somewhat cumbersome, it's technically difficult. There's a lot of extra that goes into that operation that doesn't pass the common sense test for me. Come back in 10 years, I'll tell you why you should only do an eTEP.
Well, I'll definitely look forward to that. In terms of offering IPOMs to your patients, I personally offer it only to people who are very elderly or pretty frail, and I don't want to do longer duration procedure, or patients who are obese, and pretty much simple hernias, 3 to 5 centimeters at the most, you would go beyond it, right? From what you're saying, you would extend your IPOM indications beyond it. At what point would you not do it? For example, if the patient's had an IPOM and a recurrence, and the recurrence is not massive, would you redo that IPOM, or would you extend the IPOM indication for a straightforward incisional hernia to beyond 5 to 6 centimeters? Where do you stop? When do you say that, no, this is not an IPOM case anymore?
A couple of things. If it's a small hernia with a small recurrence and the patient's had an IPOM, I've done a handful of times a redo IPOM. I don't prefer that because I don't love the idea of the mesh upon mesh, and I worry that it might trap fluid between layers of synthetic material. But I have done it successfully a handful of times. It's just not my preferred approach. As far as a straightforward first time, say, incisional hernia, up to a 7 centimeter width and defect has been my rule of thumb for what I will offer in IPOM. And I will also say I usually do a lap assisted approach for my IPOM. So I put all 5 millimeters out to the side. I'll usually put a small incision directly over the defect, drop my mesh in and close the defect there. So I would say I do more of a lap hybrid approach to my IPOMs routinely. But I find that it's a well-tolerated operation. As we're getting a little bigger than that, I think that's kind of the thing we were talking about earlier. What is the sweet spot for hernias that are 7 to 15 centimeters where I have a higher index of suspicion that they might need a component separation? Is that a patient that might be a better candidate for maybe a robotic TAR versus an open one? And I think that's the area that we should continue to explore. But for me, up to 7 centimeters would be my IPOM preference.
Fair enough. When you do these post-TAR recurrences, there's already mesh, there's already a breached retroperitoneal plane, extraperitoneal plane, the linea semilunaris is disrupted, all kinds of messy anatomical changes have occurred. Now, easy to say, okay, don't do those cases, send it to the clinic. When one has to bite the bullet and do it, what would be, in your experience, technically helpful ways of solving the problem of going back into that TAR?
I think it's not practical to say send everything to some certain place. Some patients may require a referral, but for those who are going to get care where they are, the biggest thing is getting into the abdomen. I usually just split the mesh right down the middle if it's not already split. And then I'll usually get on the mesh itself. If it is in the retromuscular plane, I actually try to preserve the mesh. And with my Bovie, I get right on top of the mesh and stick directly to that and ride the mesh all the way back into the peritoneum, into the retroperitoneum. Technical challenges specifically relate to staying on top of the mesh without breaching it with the Bovie. That takes a little bit of experience and work and good tension and exposure. And then the other thing that we always have to look out for is many times there are some neurovascular bundles which are preserved and that are still intact. And staying off of those and trying to preserve those with the repeat dissection, I think, is very important for their post-operative function. If both linea semilunaris are completely disrupted, I also manage the expectation that they'll get good tension and contour back on their abdominal wall because we know that won't happen. And then finally, if the deep inferior epigastrics are intact, I do everything in my power to try to preserve them. So those are just the technical things that we see. Many times, if there's no linea semilunaris injury, we don't have to get all the way back. If we can just take the posterior sheath down with the mesh on top of it, sometimes that's enough. And you can just close that, put a new piece of mesh there, close the anterior sheath and get out. If it's just a midline recurrence without a linea semilunaris injury of any sort, then those cases can be more straightforward than surgeons might expect them to be.
So you wouldn't normally go, say, above the level of the incision and go under the falciform or into that subdiaphragmatic subxiphoid area and develop the plane and then come down laterally?
I don't necessarily go from top to bottom or bottom to top. I just go where it's easy. We routinely will go into that subdiaphragmatic space for these redos because the goal is to get my mesh above wherever the last dissection is. If it looks like the prior surgeon was not in that space, that's commonly a great area to go into. And then the other thing to think about is sometimes if it's difficult to identify where the transversus abdominis is or where to get into that preperitoneal plane, if you look at the costal margin, you can commonly go at a 90-degree angle with the Bovie and Bovie against the costal margin and drop right into that subdiaphragmatic plane. And if the prior surgeon has not been there, that plane is commonly the most friendly one to get into. That's not always the case. So I don't necessarily plan to start in that area, I open the midline and see where it looks like the friendliest area is to go. And you may not know the answer to that. Sometimes there's been a large retromuscular dissection with just a small piece of mesh placed there. And if you go either above or below that, you'll have a safe place to go.
Ajita herself was supposed to be president of the American Hernia Society. You never actually became president, and I believe that you withdrew from your position as president to be. Can you tell us why?
So I think that commonly as we are approaching leadership positions in professional societies, it's deeply important to all of us that the societies are going in a positive direction for the membership, because the role is really in service of the members of the organization. And at the time, the organization was suffering from some difficulty. As you likely know, there was a lot of administrative turnover in the organization for various reasons that I won't go into here. That said, I think that we had for a while lost our way in terms of what we were providing in terms of value for our members and how are we growing as an organization? Are we heading in the right direction? And I had some philosophical differences with the board about that. And I did share that with them in our own communications. I shared those concerns with them. I think sometimes when there are deeply rooted philosophical differences in position of where should a society be going, it's important for us to reflect on why we're in the role and in our service. Are we providing the service that we plan to provide for our members? And at that time, I didn't feel that that was the case. I did step down from that position. It's not something that I've regretted since then. I do think the organization is a good one, and I think it's one that our surgeons should continue to get involved in. It should continue to grow what we are doing. The topics of conversation are headed in a very positive direction. They've had 2 very successful meetings since that time. And so I continue to support the organization and I wish them well.
When you become president, you can guide the organization in the direction that you choose, isn't it? That's the whole point.
I would say arguably 1 year in that position is a very short time to achieve a major change. I can also just say that, sitting in leadership, when you're in the executive council of a board, that usually implies you've been around for several years. So maybe we're looking at trends of things over time as opposed to a very short duration of a presidency of an organization in which largely grassroots efforts really won't come to fruition for likely years and years.
Ajita, you've been mentored by the best in the business. Can you tell us about which 2 people you would rate as your most important influence?
I think the 2 people who have influenced me most in my surgical practice are Mike Rosen and Todd Henneford. And I've been fortunate to learn many things from both of them. From Mike, I would say everything from leadership to research to clinical care of patients. From Todd, those things and technical excellence and the demand and the drive to be better in the operating room. Those are non-negotiables for both of those surgeons. They're both outstanding and, as we know, world-renowned in that regard. And I think what sets both of them aside is that they share that generously with their trainees. And they share that with the surgical community in a way that is notable and outstanding. So I've been very fortunate to work with both of them. And I think that they have taught me about drive, about discipline, about the care of patients, about leadership, about academic inquiry, and just in general, prioritizing my values as a surgeon. So I've been very fortunate in that.
Thank you. Well, that's all we have time for on episode 7. As always, it's my privilege to thank Ramana and our guest, Ajita. Thank you for joining us once again. It's never too late to like and subscribe to the channel, and we look forward to your company in episode 8. Thank you and good luck.
Thank you.
Thank you for watching the vodcast, and please look out for the next episode. The Hernia Hub team welcomes all comments and feedback and invites you to share these via our email address, herniahub@gmail.com.